Okay, so let's go through this again with all the information we have above, because I think people are likely starting to understand the concept of all these different terms, which will come up again and again. So this might be a bit repetitive, but I think it's totally worthwhile. So the first one is stable angina. This is not urgent. This is someone who gets chest pain or chest pressure from the imbalance of oxygen supply versus oxygen demand to the myocardium. So if you start to run and exert yourself, there's more oxygen demand. And if you have a partial blockage in a coronary artery, the O2 supply can't increase enough, so you get ischemic chest pain. So it's usually caused by a stable plaque impeding blood flow that occurs with activity, and there's just not enough blood flow to get across the stable plaque in the coronary artery during exertion. This typically resolves by sitting down and resting and taking a nitro tablet sublingually. There has been no muscle infarction. This is reversible ischemia, meaning you had ischemic chest pain that's reversible when you stop and take a nitro. There's been no muscle death, no rise in troponin ever. Acute coronary syndrome we've gone over. This is a higher degree of blockage. There's been plaque rupture, and the first one is unstable angina, which in itself is concerning because it can continue blocking up and lead to an MI. But unstable angina, you haven't had an infarction. You have a critical blockage, and the pain is unpredictable. It's coming and going at any time. You can get arm pain, jaw pain with it. There's been no heart attack yet, but if left without treatment or not diagnosed, you are at high risk for going on to have one of the two types of heart attacks. Okay. The next one is an NSTEMI, a non-ST elevation MI. It is definitely a heart attack because of the increased troponin. So there's been myocardial cell death, but there's no ST elevation on ECG, and that's how we distinguish between the two. It's not a full thickness heart attack compared to a STEMI, which is a full thickness heart attack with an elevated troponin, and this we treat as emergent for thrombolytics or the cath lab. Okay, so if you have troponin in the bloodstream, it can only be one of two things: an NSTEMI or a STEMI. Okay, so let's do this question slide. A patient diagnosed with coronary arterial disease is most likely to have A. Peripheral artery disease, degenerative joint disease, a history of atrial fibrillation, a history of renal insufficiency. So arterial disease, atherosclerosis, which is plaque formation throughout the arterial system. If you have it in one location, such as the coronary arteries, you very likely have it in other locations, such as your legs. You can have atherosclerosis to your kidneys, to your brain. So it's a diffuse disease of the arteries. So the answer would be peripheral artery disease. Very likely. So if I see peripheral artery disease in a patient, then it makes me much more suspicious that they have coronary artery disease as well. So this slide, which requirements for effective oxygenation and perfusion. So let's just spend a bit of time. This slide kind of got put in there. I think it's a nice slide to keep, but it's just a concept slide for you to bring ideas together in your mind. So what do you need for oxygen to get from the air to the cells in your body, all over? Okay, because that's really what you need for aerobic metabolism. You need oxygen to get from the air and make it all the way to the cells. So the first thing you need is adequate ventilation. And we've gone through this before. Ventilation is just the act of breathing in and out. You need diffusion, which is the process where oxygen diffuses from the alveoli to the capillaries and then taken away, and it's bound mostly to hemoglobin, which is the main carrier of oxygen in the bloodstream. And then it's carried away from the lungs, goes to the left side of the heart, the left atrium, left ventricle, and pumped out. So you need an intact pulmonary circulation. So you need the pulmonary artery to pump it to the lungs. You need the pulmonary veins to return it to the left atrium. And then you need proper pumping of the heart. So your cardiac output has to be appropriate, which then brings into stroke. Do you have a normal stroke volume? Do you have a normal heart rate? So all these aspects of cardiac output are controlled by the autonomic system, which controls heart rate. Don't forget about the electrical system in the heart, which is creating the heart rhythm. So it's coming in from the air, proper ventilation, proper diffusion into the bloodstream from the alveoli, proper cardiac output. You also need proper amounts of hemoglobin, so you shouldn't be anemic, so that you can carry the proper amount of oxygen on the hemoglobin. So an intact circulation. You need an intact coronary circulation to keep the heart pumping. So if your coronary arteries are diseased, well, you're going to have heart attacks, unstable angina. You'll end up with heart failure, and you won't be able to provide proper cardiac output. And then you need an intact circulation throughout the whole body to transport the oxygen, which is in the red blood cells on the hemoglobin, to the body. So that's more of just a concept, but the more you can put things together, the more things will make sense later, and you'll be able to problem solve. Okay, so let's pound these concepts home so they stick. Repetition is the key to all of this. That you just hear it multiple times, and finally it just sticks in your brain, and you don't have to memorize as much. So when we say stable angina, you can add the word chronic. Chronic just means it's been happening for more than 3 to 6 months. But stable angina is just how it's described. It's intermittent chest pain that is stable over a long period of time with the same pattern of onset, duration, and intensity of symptoms. So if a patient comes in and says, listen, I've had angina for years. This is totally different. I'm getting it 15 times a day. It's totally unpredictable. It feels the same, but the duration is lasting longer. The onset is different. Well, then we have to start thinking that it's not stable angina anymore. So really, stable and the patient usually knows when they have stable angina because they've had it for a long time. And the main reason for stable angina is the insufficient blood flow during exertion. And the insufficient blood flow is from the narrowing of the coronary arteries from atherosclerosis. And we've spoken about this quite a few times, where atherosclerosis and the plaque formation in the arteries creates an oxygen supply versus an oxygen demand inequality. So if you demand more of your heart by exercising with activities, and you can't receive enough supply of the oxygen that's being demanded, then you will get ischemic symptoms and ischemic chest pain. So this anterior pressure, tightness, It's often not even called pain by the patient. They use other terms like tightness and pressure and indigestion sometimes. So we're very liberal about doing ECGs, even if someone comes in saying they have some indigestion. We'll still check it with an ECG. The discomfort can be referred to the shoulders, to the arms, to the neck. Very common to have radiation of the symptoms. Now, stable angina, you sit down, you let the heart rest and start to slow down in terms of how fast it's beating, and a nitro tablet or a spray. There's also sprays that are available, but nitro tablet, and typically by doing this, the symptoms completely resolve. Okay, so there's plaque stability, there's no rupture of the plaque, and the chest discomfort is very predictable, and the resolution is very predictable. So this is not an emergency. This can go on for years like this, and treated with a number of medications to minimize the symptoms, and also having nitro tablets with you if needed during an anginal episode. Okay, so let's increase the urgency. And we've done a case of this, but let's talk about it. Acute coronary syndrome is made up of those three disease states, or those three conditions: unstable angina, NSTEMI, or STEMI. Okay, so those are a much more urgent, they're urgent conditions because, well, for one, unstable angina is on the way to having a heart attack because the plaque has ruptured, and the artery, the coronary artery, is almost completely blocked, and you're getting unpredictable anginal symptoms. An NSTEMI, you've already had an infarct. You've already released troponin, so you need in-hospital care for that. And a STEMI needs urgent fibrinolysis with a thrombolytic, or the cath lab for possible angioplasty and stenting. So on the right, this just puts it into a bit of a diagram for you. ACS is broken into a STEMI, which is either the cath lab or a thrombolytic, because you have ST elevation. On the other side is non-ST elevation ACS, and there's two in there. If the troponin is negative, then it's unstable angina. If the troponin is positive and you don't have ST elevation, so you have an NSTEMI, well, that's a heart attack, purely because the troponin is positive. And with these, whether it's unstable angina or NSTEMI, you do get ECG changes. Okay, we can see them on ECG often, not always, but if you look at the left side where it says non-ST elevation ACS, and right beside it, it has ST depression, T wave inversions, so flipped T waves, and sometimes a normal ECG, and you can still have a heart attack in the setting of a normal ECG. So ECG isn't foolproof, but it is a fantastic test because we can often pick up abnormalities from ischemia or from an infarction on an ECG. So we can start to go through these relatively fast because this is a repetition. Acute coronary syndrome. The plaque has ruptured in the coronary artery. What can it include? Well, unstable angina. This very unpredictable pattern in the usual pattern of angina. It's new. It can be new in onset. This pattern. It can occur at rest. sleeping, activity. There's no way of predicting it. It tends to have a worsening pattern. It's increased in frequency, but there's been no permanent heart damage yet, no positive troponins. Okay. The ECG can show signs of ischemia, and the two listed there, ST depression. There's a segment of the ST, if you wanted to go back to one of the top slides at the beginning of this module, there's an ST interval, and that can be depressed when you have ischemia, and T-wave inversion is another one. Remember, the troponins are always negative with unstable angina. There's been no heart attack. Okay, acute coronary syndrome, myocardial infarctions. So I'm going to say this enough that everyone will remember it for next semester. Because it really is important, and if you don't get it at the beginning, it's really hard to understand it later. So the first one is non-ST segment elevation myocardial infarction. So non-ST segment elevation on the ECG is what we're saying. And that's an N-STEMI. How do we know it's an N-STEMI? Because the troponins are positive. You've had an infarction by the very fact that you're leaking troponins into the bloodstream. And it's usually a partial thickness infarct. And we refer to it as a subendocardial infarct. So it's the tissue, it's the muscle right below where the endocardium, the endocardial lining of the chambers of the heart is. So it's not a full thickness infarct like a STEMI, an ST elevation MI on ECG, which is a complete occlusion of the coronary artery, and it's a full thickness myocardial infarction. Okay, so what happens with continued ischemia? So if you have a blockage and you're ischemic to a part of the heart, there's going to start to be cell death, infarction, or another term is necrosis, with release of troponin into the bloodstream. So the necrosis or infarction of the entire thickness of the myocardium can take 4 to 6 hours. And that's why when someone comes in with chest pain and the first troponin is negative and they've only had chest pain, say, for an hour, we'll keep them in the hospital and repeat the ECG and troponin in about 6 hours, because it can take that amount of time for the troponin in the bloodstream to turn positive, for it to be released, and for it to turn positive on our testing. Okay, so infarction means MI, myocardial infarction. We often do repeat ECGs and troponins 4 to 6 hours later to see if there's been any leakage or elevation of troponin in the bloodstream. There's typically 4 locations of the heart where you can have a heart attack, an infarct. The front of the heart, anterior, the bottom of the heart, inferior, the side, the left side of the heart, which is lateral, and the back of the heart, which is posterior. Those are the 4 most common places to have an MI, and it just depends on which artery is blocked, which will decide where the infarct happens. Okay, so let's just reinforce this concept of myocardial infarction, which is the medical term for heart attack. So we split heart attacks into 2 types based on the ECG. There's an N-STEMI, so a non-ST elevation myocardial infarction, which is on the left there, and a STEMI, an ST elevation myocardial infarction. So let's go back to an N-STEMI. So there's typically partial occlusion of an artery that has severely occluded the artery, and a bit of blood is still trickling through, but there's been myocardial death downstream to the artery and release of troponin. You're always going to have a positive troponin in the setting of any kind of a myocardial infarction. An NSTEMI is a partial thickness myocardial death, meaning that if you can think of the left ventricle as a thick muscle, only the inner layer of the muscle that's close to the chamber has started to die. Okay, and this can die with that arterial blockage of the coronary artery within 20 to 30 minutes. And if we look below, we'll see that the underlying problem is plaque rupture. And if it's a partial occlusion, but still very severe, you're going to get what we call on an ECG with an NSTEMI, ST depression. Don't worry about that too much right now. That's an ECG for another talk. If you get complete occlusion, now we're going to be talking about a STEMI, right? An ST elevation MI. And that's where you can see on this image here, the ST segment of the QRS is now elevated. Okay? And this is really from total occlusion of the coronary artery, and you have full thickness myocardial tissue death. Okay, and this typically takes 4 to 6 hours to occur. A STEMI is a cardiac emergency. We want to get that artery open as soon as possible. So whether it's with very, very powerful thrombolytic drugs, or it's with a trip to the cardiac cath lab to open it up with a cardiac catheterization and a stent, either one of those to get the artery open so blood can start flowing to the part of the heart that hasn't been receiving blood for potentially hours, to minimize the extent of the damage. Okay? An NSTEMI isn't typically an absolute emergency in terms of getting to the cath lab to open up the blood vessel. And we do not use thrombolytic drugs, which are very powerful anticoagulants, to open up the blood vessel. We do use other drugs to try and open up the blood vessel, but it's not as much of an emergency as a STEMI. Okay, so this slide is really just for you to see that when we look at an ECG and we're looking at different parts of the ECG, that we can determine which part of the heart is being affected, say, from a heart attack, such as an NSTEMI or a STEMI, because the different leads show us different parts of the heart. So, for example, the anterior part of the heart, the front part of the heart, is being shown by V1 to V4. The lateral part of the heart is being shown by a number of leads that aren't directly connected, but that's the left side of the heart. And then finally, the inferior part of the heart, the part that's sitting on the diaphragm, is another set of leads called 2, 3, and AVF. So this is just to give you an idea that we can actually determine where a heart attack is based on which part of the ECG we're seeing the ST elevation. Okay, so let's do this question together. What diagnostic test reveals myocardial injury? So troponin, 12-lead ECG, chest x-ray, or a cardiac CAT scan? Well, it's definitely going to be troponin, right? When heart muscle dies, it releases its contents into the bloodstream, and myocardial cells have troponin within them. and we can detect troponin in the blood test. And that is actually how we initially diagnose a heart attack, by detecting troponin within the blood tests. Okay, a 12-lead ECG can definitely help us be suspicious and also diagnose heart attacks, but really the troponin has told us there's myocardial cell death. The chest x-ray can show us an enlarged heart, but it's not going to tell us anything about whether there's been cell death. And the same thing goes for a cardiac CAT scan. It's going to give us an assortment of information about the chambers of the heart, what the coronary arteries look like, but it's not going to tell us that there's been definite cell death and release of troponin.